Swayam Prabha. Digital India. Educated India.
So today what we will be discussing is the normal physiology and anatomy of brain. Why it is important to know, normal anatomy of brain is because unless you know the normal anatomy and normal physiology, you cannot know pathology. Okay. And I would like to tell you that normal anatomy of brain is very, very distinct from other parts of the body. For example, if you look at, GI tract, if you look at uterus, if you look at other organs in the body, there is something common. But brain has its own distinct histology, okay, which we must know if we are interested in knowing what is happening in the brain. So this is the first lecture which I am taking, and we'll be discussing what happens in the brain and what is the normal anatomy. So if you look at the structures of the brain is covered by meninges, which is got three layers, the dura, arachnoid and the pia. Then parenchyma of the brain can be divided into grey matter and white matter. And, grey matter primarily comprises of neurons and white matter primarily comprises of the supporting cells, which are known as the glial cells and their supporting cells. So glial cells are astrocytic cells, oligodendroglial cells, ependymal cells, and their supporting cells are microglia. Okay. And it is through the white matter that you have and then you have the ventricles, which are primarily lined by the ependymal cells. Okay. And why do you want to know about the astrocytic cells, the oligodendroglial cells or the ependymal cells? Because there are many lesions which are associated with these cells, which I'll be covering in this lecture. Then you have the blood vessels and the cranial nerves. Now first we'll discuss the white matter. White matter, as you told you, is comprised primarily by neurons, and the neurons, when they are seen in some areas, they are seen in clusters, and those areas are known as nuclei. Okay. And similar neurons, which are called as ganglion cells, are seen in the spinal cord and as ganglia in the peripheral nervous system. And the difference between a neuron and a ganglion cell is that a ganglion cell is covered by a layer of sustentacular cells. Okay. As you can see in the third picture, there is a group of ganglion cells, and this group, when they are arranged in a group, they are known as ganglia. And each ganglion cell, as you can see, the cytoplasm is covered by sustentacular cells. And the cytoplasm of the neuron has nissl substance, and basically this nissl substance is nothing but rough endoplasmic reticulum. If we come at white matter is primarily comprised of myelinated axon bundles and the supporting glial cells, primarily astrocytes and oligodendroglial cells. And it is the myelin which is responsible for white appearance of the white matter. Neurons are very, very sensitive, and once a neuron dies, it can never be replenished. Like in liver parenchyma, if you have some component of destruction of liver cells, then they can revive. Our skin can revive, but neurons can never revive. So a neuron, if dies, it dies forever. And neurons are very, very sensitive to injury. So now coming on to what are the reactions which can happen to neurons in a state of injury. For example, if you have an axonal injury, what happens is that the axon, which is distal to that area, will undergo degeneration, and this is known as Wallerian degeneration. And there are some changes which occur in the neuron also, which is in the proximal to that. Those changes which occur in the neuron is known as chromatolysis. Now, what happens in chromatolysis? What is the cause of chromatolysis? It can be trauma, it can be infection, it can be infarction, or it can be, epileptic seizure. Any insult to white matter will ultimately cause insult to the neuron also. Now, look at this picture. It is showing you changes of chromatolysis. So, there is dispersion of nissls bodies, okay, which go to the periphery. As you can see in this picture, in the top picture, the nissl substance has gone to the periphery, and the nucleus, it goes to also to the periphery of the cell, and the cell body becomes swollen. Now coming on to second reaction, now the second change which can happen in a neuron is known as ischemic change. So in ischemic change, what happens is the neuron, the cell becomes pycnotic, the cytoplasm becomes, very, very eosinophilic, and the nucleus can undergo three changes which are known as karyolysis, pycnosis or karyorexis. So what happens in karyolysis is that the chromatin material in the nucleus, it fades away. In pycnosis, the nucleus becomes, shrunken in shape, and in karyorexis, the nucleus gets broken. Okay, so these kind of neurons which have undergone ischemic change and they have bright eosinophilic cytoplasm and they are shrunken, they are known as angry red neurons. Okay. Now, coming on to the third reaction of the neuron, it is the loss of neurons. As I told you, neurons are very, very sensitive to injury, and neurons once lost are lost forever. And there can be acute loss of neurons or chronic loss. Acute loss can occur in a state of hypoxia, hypoglycemia, or there is any viral infection, and chronic loss can occur by aging, as a part of aging, as a part of dementia, or as a part of even a chronic epileptic state in degenerative disorders of the brain like motor neuron disease or infections like CJD. Now fourth change which occurs in neurons as a result of insult to the neurons is intraneuronal inclusions. So intraneuronal inclusions can be either in the nucleus of the neuron or in the cytoplasm. So in most of the viral infections, the inclusions which are seen in the neurons are in the nucleus, and in most of the degenerative conditions, you see the inclusions in the cytoplasm of the neuron. So this is just to show you a picture of cytomegalovirus infection showing intraneuronal inclusion. This is herpes simplex 1 infection showing intraneuronal inclusion. And this is an example of again a viral infection, rabies. This is the one of the viral infections, the only exception where the inclusions are seen in the cytoplasm, and these are known as Negri bodies. And in most of the degenerative conditions, you see intracytoplasmic inclusions in the neurons, and these can be in the form of neurofibrillary tangles, Lewy bodies in Parkinson's, Pick's bodies in Pick's disease. So you should not confuse Pick's disease with Niemann-Pick's disease. So this is a basically degenerative condition of the brain which I will be covering, and Lafora bodies can be seen in myoclonic epilepsy. So this is just a picture showing you three brains. The first brain is, this is a normal brain, this is an aging brain, and this is another shrunken brain which is seen in Alzheimer's disease. So what happens when you have aging or Alzheimer's disease is that in these cases the ventricle gets dilated and there is atrophy of the white matter as well as the grey matter, and as a compensation to that the ventricle is dilated. So look at this picture in the right, the ventricles are not dilated, but in the left the ventricles are dilated because this is a brain which is undergoing atrophy, and the ventricular dilatation is a part of compensative mechanism. Neurofibrillary tangles are basically hyperphosphorylated proteins which are seen primarily in neurons in the area of their cytoplasm, and it's a marker of Alzheimer's disease. So, if a brain specimen comes to you, so knowing all these accumulations is very, very important. Then only you can reach a correct diagnosis. Hyranobodies are again actin filaments. These are seen in neocortex and hippocampus, and they are not specific to any disease. But it has been seen that these are more commonly in people who have undergone dementia, although they have no relation to dementia, but the frequency of presence of Hyranobodies is more in dementic patients. And in Pick's disease is characteristically, the presentation would be similar to Alzheimer's, but it involves frontotemporal region of the brain and is known as frontotemporal dementia. And it's quite rare as compared to Alzheimer's. But what is characteristics of Pick's disease is presence of intracytoplasmic inclusions which are known as Pick's cell. And as you can see in this silver stain section, they stain very well with the silver stains, and these are known as Pick's bodies. Okay. So then similarly, Lewy's bodies can be seen in substantia nigra in people with Parkinson's disease, and again, now coming on to the next reaction of the neuron, it is intraneuronal storage deposits. Storage deposits are mostly seen in the cytoplasm. Lipofuscin is a pigment of aging and degenerative process which is seen in the cytoplasm of neurons, and in other organs also you can see lipofuscin pigment. As you know, the pigment deposition increases as the person ages. And other storage deposits which can be seen in neurons are lipid and mucopolysaccharides, and you can have iron deposition also in cases of old hemorrhage. So these are two pictures showing you lipofuscin pigment in a PAS stained section, and this is a fluorescent stain showing you fluorescent pigment, which is again lipofuscin. So these were the reaction of the neurons in the form of chromatolysis, ischemic change, loss of neurons, and intranuclear and intracytoplasmic deposits of material. Okay, and then I have shown you storage material also. So these are the kind of responses which a neuron undergoes to any insult. Okay, so that covers the neuronal part. Now coming on to the glial cells. As I have told you, glial cells are of three types: astrocytes, oligodendroglial cells, and ependymal cells. The typical histology of an astrocyte is that, as you can see, in the center of the cell there is nucleus, then there is abundant amount of cytoplasm, and you can see numerous processes. Okay, so astrocytic cells have numerous processes which can be stained very well with GFAP stained. Now, why am I discussing these processes with you? So as we, go further in this lecture, you will know what is the importance of these processes. The oligodendroglial cells have, relatively fewer number of cytoplasmic processes, and the main function of oligodendroglial cells in the brain is that they help in formation of myelin sheath. The third cell is the ependymal cells, and these are the epithelial cells which line the ventricular spaces, so they form the ventricular lining in the brain. Now, what are the reactions of these glial cells? So, mostly it is the astrocytes which bear the brunt of the injury, but as compared to neurons, they are relatively more stable cells, and the common reactions which an astrocyte shows to injury is number one, loss, and number two is hyperplasia and hypertrophy. I think you know the difference between hyperplasia and hypertrophy, but just to, revise, hyperplasia is increase in the number of cells, and hypertrophy is increase in the size of the cell. As a reaction to injury, the astrocytes, they increase in their number and they increase in their size also, and this process is known as gliosis. So now in next picture you see, picture number 1 is H&E stained section. This is showing reactive astrocytes. These are known as gemistocytic astrocytes, but you cannot appreciate that these astrocytes have so many processes, but once you have put GFAP stain, you can appreciate numerous processes coming out of each and every astrocyte. So they appear like stars. So this is immunohistochemical stain GFAP, which helps us in recognizing these cells as reactive cells. Okay, had it been a neoplasm, you would not have seen so many reactive processes. So that's where knowing normal anatomy is important to know the pathology. Now, other reactions which can be seen in astrocytes are inclusions, like viral inclusions. For example, you can see in herpes, measles, and you can also see storage deposits. And number 5 is presence of rosanthal fibers. What are rosanthal fibers? These are basically dystrophic astrocytic processes, and can you see in this picture, they can be seen as longitudinal fibers, and you can see as cross sections also. Okay. So, presence of rosanthal fibers indicates that it's a long-standing process. Okay. So, long-standing process can be any chronic illness or a grade 1 neoplasia. For example, pilocytic astrocytoma. So, presence of rosanthal fibers indicates a long-standing injury. Now, next reaction which you can see in astrocytic processes is presence of corpora amylaceae. It's again a material which gets accumulated in the brain with aging. And you can also see presence of abnormal astrocytes in diseases like Wilson's disease, where they are known as Alzheimer type 2 astrocytes, but they have nothing to do with Alzheimer's disease. Okay. So, they are only known as Alzheimer 2 astrocytes. And there is a disease called progressive multifocal leukoencephalopathy, which is seen in patients with HIV, and in this disease also you can see abnormal astrocytes. So this covers what are the reactions of astrocytes to injury. Okay, in the form of loss, in the form of hypertrophy and hyperplasia, okay, in the form of presence of intranuclear inclusions, then in the form of corpora amylacia, abnormal size of the astrocytes. So these are the astrocytic reactions. Now coming on to the oligodendroglial cells. Oligodendroglial cells can either undergo edema or loss. And if there is loss of oligodendroglial cells, it will lead to demyelination, because I have told you in the beginning that oligodendroglial cells, they take part in formation of myelin. Now coming on to the supporting cells or microglia. Microglia are nothing but they are modified macrophages. And so they are the phagocytic elements in the nervous system, and in response to injury, microglia can also, undergo various changes. Okay, so when microglia proliferate, they can show you different changes, like look at this slide. They can develop elongated nuclei. These are known as rod cells. They can proliferate in the form of nodules. These are known as microglial nodules. They can surround and destroy a neuron. This is known as neuronophagia. Or they can, get distended with presence of lipid droplets in the cytoplasm, which is known as jitter cells. Or sometimes they can get together and form multinucleated giant cells in cases with AIDS. So these are various kind of reactions of microglia to injury. Now I will show you the pictures. Look at this first picture. This is a neuron which is surrounded by numerous microglia, and this state is known as neuronophagia. And the second picture shows you a microglial nodule where clusters of microglial cells are there along with lymphocytes. Then look at this third picture. Here there is formation of multinucleated giant cells here and here. This is a case of HIV, and this also. And this next picture is showing you jitter cells. The microglia cells have abundant cytoplasm, and they have a vacuolated cytoplasm which contains lipid. And this is seen mostly in cases of old hemorrhage. Now coming on to the next component in the brain, which is very, very important to maintain the homogeneity in the brain, is CSF. Okay. You should know what is the volume of the CSF, which is about 150 milliliters in adults, and out of that, it lies 20 ml approximately lies in the lateral ventricle, 5 ml in the third and the fourth ventricle, and rest of it lies in the subarachnoid space, and around 500 ml of CSF is formed per day. CSF is mostly produced by the choroid plexus, and it is absorbed by the arachnoid villi, and ultimately it goes on to the venous sinuses and reabsorbed in the body. Normal pressure of the CSF is about 0 to 15 millimeters of mercury in adults and 0 to 5 in children. And there are conditions which can lead to raised intracranial pressure, and where the pressure can go on to up to 30 to 35 or even more, and it can lead to damage to the brain in the form of ischemia. Examination of the CSF is very, very important, because different changes in the CSF can be appreciated in different disease states. So what you need to know about CSF examination is that, number one, we need to know the pressure of the CSF. Second is you need to examine in the color and the consistency of the CSF, that is the physical examination. You have to send your sample for protein, sugar and chlorides. You have to examine under a microscope for cell count and cell type. Then you have to send your sample for smear and culture. And you can also send it to cytology lab and serology and electrophoresis. High pressure of CSF can occur in states like meningitis. Why? Why there would be high pressure? Because in meningitis, when the meninges, they get inflamed, there is fibrinopurulent material, it hampers absorption of the CSF. In case of meningitis, the absorption of the CSF decreases, or there is any space occupying lesion in the brain, which is obstructing the flow of CSF, that will also lead to hydrocephalus and high CSF pressure. And then low pressure can be seen in states of shock and dehydration. Physical examination, CSF normally is clear and colorless. It can be turbid in case of pyogenic meningitis. There can be presence of fibrin clot in case of tubercular meningitis. Bloody tap can be seen in traumatic injury or subarachnoid hemorrhage. Now, knowing about protein, sugar and chloride levels of CSF is very, very important. For example, high proteins in CSF can be seen in pyogenic or tubercular meningitis. Normal sugars is seen in patients with viral meningitis, and low sugar can be seen in pyogenic and tubercular and fungal meningitis. Similarly, high chloride levels can be seen in kidney failures and low can be seen in states of vomiting or diarrhea. Microscopic examination of the CSF is very, very important. For example, if you see numerous neutrophils in a CSF sample, that indicates pyogenic meningitis, and if you see lymphocytes, that would indicate either a viral disease or tubercular meningitis. Okay, so cell type and cell count both are very, very important to which disease process we are looking at. You can stain your CSF sample for Gram stain and Zn stain for looking at which kind of bacteria it is and to look for acid-fast bacilli. You can, to look for fungal stains, you can do India ink preparation, which is very easy to do in a side lab. You can send the sample for culture, cytology, serology and protein electrophoresis. Now, coming on to raised intracranial pressure, it can be, in the form of cerebral edema or hydrocephalus. When we talk of cerebral edema, edema can be of three types. It can be vasogenic edema, which is mainly due to damage to the blood-brain barrier. It can be cytogenic edema, which is basically damage to the cells, for example, the neurons or the astrocytes. And in interstitial edema, what happens is that the CSF penetrates in the white matter, in the interstitial space. Now, vasogenic edema can be, due to inflammation. It could be vascular, trauma or neoplasm. Vasogenic edema, what you see is normally, vessels, either they become abnormal in shape, size or they abnormally proliferate. Mostly, vasogenic edema is a component of neoplasia, due to abnormal proliferation of blood vessels. It can be a component of trauma, vascular diseases or inflammation of the vessel. So basically the vessels become leaky and the fluid starts going out of the vessels. Cytotoxic edema is very, very characteristic. So it is at the cellular level. Either there is anoxic injury or toxic injury to the cell itself. So in vasogenic edema, there is breakdown of the blood-brain barrier, and in cytotoxic edema, if you remember your sodium-potassium pump, which works at the cellular level, there is impairment of the sodium-potassium pump. And so vasogenic edema, enlargement of the extracellular space, but in cytotoxic edema, there would be no enlargement of the extracellular space. But individual cells will be undergoing swelling. It can be swelling in the neurons or in the glial cells. In vasogenic edema, you will see accumulation of fluid either around the space occupying lesion or it would be diffuse in the white matter, but in the cytotoxic edema, the swelling would be inside the cells. So that is the basic difference between these two processes. The fluid component in the vasogenic edema is plasma filtrate, whereas in cytotoxic edema, it is plasma ultrafiltrate. But vasogenic edema is much more common as compared to cytotoxic edema. Now coming on to hydrocephalus. Hydrocephalus can be of three types. It can be non-communicating or obstructive hydrocephalus, for which the commonest causes are, number one, acquired cause of hydrocephalus would be a neoplasia or a space occupying lesion. And the second common cause is congenital malformation. For example, there is any obstruction to the flow of CSF, obstruction to the foramen of Monro, there is any stenosis of aqueduct. So these are the causes of hydrocephalus, which can be either congenital or acquired. So what would be, there would be obstruction to the flow of the CSF. It won't be able to go distal, and because of the obstruction, there would be dilatation of the ventricles and eventually there would be leak of CSF. Now again, it can be malabsorptive hydrocephalus. Malabsorptive, I have told you what would be the commonest cause of malabsorptive hydrocephalus. The commonest cause is when there is an infection or any inflammation in the meninges, it will lead to loss of, the absorption of the CSF would be hindered. And third is compensatory hydrocephalus, which occurs when there is compensatory, I showed you a picture, dilatation of the ventricle, especially in cases with aging or dementia. Normal pressure hydrocephalus is seen in elderly patients, and it is basically, it can be idiopathic or, it can be secondary to subarachnoid hemorrhage or in head injury. So the ventricles are dilated, but the intracranial pressure is normal. So that is the end of the first lecture.